All right, let's jump straight into this high-yield explainer on structural, chronic, obstructive, and infectious renal pathology for Step 2CK. We are focusing entirely on next best step decision logic, the underlying mechanisms, and of course those classic exam-facing traps.
We'll be breaking down our clinical decision-making into 4 distinct folders: structural defects, chronic functional failure, acute obstruction, and finally, infectious pathology.
Starting off with Block 1, structural defects. The absolute first critical branch point you need to master is differentiating a totally benign simple renal cyst from a potentially malignant cystic mass.
Now, when you're looking at the imaging, a simple cyst is pretty straightforward. It's going to have paper-thin walls, absolutely zero solid components, and a distinct lack of any contrast enhancement. On the flip side, a malignant cystic mass is going to look angry. Thick, irregular walls, a messy mix of solid and cystic components, and clear contrast enhancement.
So your next best step logic here is incredibly simple. If the imaging shows a unilocular, homogeneous cyst with smooth walls, bam, no follow-up required. You're done. But the second you see multilocular features, multiple septi, heterogeneous contents, or literally any contrast enhancement, that mandates immediate follow-up imaging and a urology consult to rule out malignancy.
Okay, let's say a 30 to 40-year-old patient walks in presenting with flank pain, hematuria, and you can actually palpate bilateral abdominal masses. You need to immediately suspect autosomal dominant polycystic kidney disease, or ADPKD. You'll confirm this with an ultrasound showing multiple renal cysts. And remember, for management, you've got to aggressively control their cardiovascular risk factors, specifically relying on ACE inhibitors to tackle that hypertension.
But here's the classic exam trap, the extrarenal features. While cerebral aneurysms are definitely the most dangerous complication, a real ticking time bomb, do not forget that hepatic cysts are actually the most common extrarenal complication of ADPKD.
Moving right along to Block 2, let's map out chronic kidney disease and the complications associated with end-stage renal disease.
Think of chronic kidney disease as a systemic failure to excrete. The body just stops clearing out the garbage. This means reduced excretion of potassium, phosphate, acid, and fluid, right alongside a drop in erythropoietin production. Because of this, these patients are super prone to volume overload, hyperkalemia, and metabolic acidosis. You've got to impose strict dietary limits on fluid, potassium, and phosphate to stop them from rapidly progressing to severe uremic symptoms like encephalopathy or pericarditis.
When we talk about CKD, mineral bone disease, you have to be able to differentiate the exact type of renal osteodystrophy. Because of phosphate retention and low calcitrol, hypocalcemia kicks in and drives secondary hyperparathyroidism. This leads to osteitis fibrosa cystica, which features high PTH and high bone turnover. On the other end of the spectrum, adynamic bone disease gives you low PTH and low turnover. But here's the kicker. Both of them significantly decrease bone mineralization and massively increase fracture risk.
And please, never forget this. Cardiovascular disease is the absolute most common cause of death in dialysis and renal transplant patients. We're talking roughly 50% of all deaths here. This is heavily driven by ESRD-specific risk factors, namely vascular calcifications from all that high phosphorus and calcium, combined with intense oxidative stress related to the uremia.
Now, a truly severe complication you need to recognize on site is calciphylaxis, also known as calcific uremic arteriolopathy. This causes arteriolar and soft tissue calcification that literally chokes off the blood supply, leading to local tissue ischemia and necrosis. Clinically, you're looking for intensely painful nodules and ulcers, usually showing up in areas with more adiposity, like the trunk or thighs. And a huge distinguishing factor, unlike standard atherosclerotic ischemia, their peripheral pulses will remain completely intact.
What drives this? Well, hyperphosphatemia and hyperparathyroidism are the major culprits. Also, watch out for oral anticoagulants, like warfarin. They act as potent triggers because vitamin K is normally what prevents that vascular calcification. And here's a massive trap. Having normal serum calcium levels absolutely does not rule out calciphylaxis. The local tissue calcium concentrations can be through the roof, even if the systemic labs look fine.
All right, transitioning to Block 3, acute obstruction. Let's lock in the diagnostic and treatment logic for nephrolithiasis.
The classic presentation is unmistakable. Sudden, severe, colicky flank pain that radiates straight down to the groin, usually accompanied by hematuria. Now, for your standard non-pregnant adult, a non-contrast CT is the absolute gold standard diagnostic test. But if you're dealing with a child or a pregnant patient, a renal and bladder ultrasound is mandatory to spare them the radiation exposure.
Speaking of pregnancy, if a pregnant patient comes in with suspected renal colic, you always begin with a renal and pelvic ultrasound. If that comes back negative, but your clinical suspicion is still high, the next best step is a transvaginal ultrasound. Only if that is also negative should you even consider a low-dose CT urogram, and that is strictly reserved as an absolute last resort during the second or third trimester.
Management entirely hinges on the stone's size and the patient's clinical stability. For tiny stones under 5 millimeters, conservative management, just hydration and pain control, is totally fine. If the stone is between 5 and 10 millimeters, you want to initiate medical expulsive therapy using an alpha blocker. But if that stone is larger than 10 millimeters, if the pain is intractable, or if you see any signs of infection combined with obstruction, you admit the patient and get urology on the phone immediately for urgent decompression.
Here's a radiologic trap that catches a lot of people: stone composition. Uric acid stones, which are linked to low urine pH or gout, are radiolucent. This means a standard X-ray will miss them entirely. You absolutely must rely on a CT, an ultrasound, or IV pyelography to actually see them.
To prevent those recurrent calcium oxalate stones, you need to instruct patients to push fluids hard, aiming to produce over 2 liters of urine daily, and to cut down on sodium. But here is the major testing trap: calcium intake. Patients must maintain a normal calcium intake, which is about 1,200 milligrams a day. If you tell them to restrict calcium, it paradoxically increases oxalate absorption in the gut and leads to even more stones. Crazy, right?
Finally, Block 4, infectious. We're going to break down how to differentiate uncomplicated cystitis from complicated urinary tract infections and pyelonephritis.
So cystitis is your classic lower tract infection. It presents with dysuria, urgency, frequency, and suprapubic pain, but critically, there's no systemic illness. These uncomplicated UTIs respond beautifully to simple oral agents like nitrofurantoin, trimethoprim, sulfamethoxazole, or even a single dose of fosfomycin. However, if the infection ascends beyond the bladder, meaning you start seeing systemic signs, pelvic pain in men, or fever, you're now dealing with a complicated UTI. That requires inpatient IV antibiotics like ceftriaxone, piperacillin tazobactam, or carbapenems while you wait for cultures.
Now, pyelonephritis adds fever, flank pain, CVA tenderness, and usually some nausea to the mix. But before you just reflexively order a CT scan for a textbook case of pyelonephritis, you really need to know the strict indications for imaging.
Because routine imaging in uncomplicated pyelonephritis, it's a massive waste of resources. It is not indicated. You should only be ordering imaging if the patient presents with complicated features like obstruction or sepsis, or if they are showing absolutely no clinical response to appropriate antibiotics after 48 to 72 hours.
And let's finish out with a classic step-down therapy scenario. Say a patient is admitted with severe pyelonephritis, and you start them on IV ceftriaxone. You monitor them closely for 48 hours. Once their fever breaks and that flank pain resolves, the definitive next best step is absolutely not keeping them on a full 14-day IV course in the hospital. You transition them directly to a culture-guided oral antibiotic regimen so they can finish their treatment as an outpatient. Keep it high yield.